over the last couple weeks, last 3
This
weeks. Yeah, your internet connection is really slow. Who's ever talking? Is that you, Katie? Yeah, it's either me or you. I normally don't have any trouble. But anyway, you're moving a little bit. Anyway, so what we're going to do is I kind of picked and chose things that I think you need to focus on for your exam. How many of you in this group, and you can chat with me, are taking their exam tomorrow? Anybody? Anybody taking their exam tomorrow? Christy's on here twice. Wednesday for you, Stacy. Okay, okay, okay. So what I think we need to review is these topics: diabetes in pregnancy, preeclampsia, postpartum hemorrhage, precipitous labor, induction. Those topics in particular, those were major topics for these last few weeks. Okay, so if there's something else you want to ask me first before we can get started with some things. Okay, so a little participation would be fun for me. Okay, I have some people jumping on still, and I do want to make sure they have an opportunity to have some input, and I don't want them to miss anything. Hi, Kimberly.
Hi, Professor. Good night.
I was hoping there would be more people, but I understand. All right. I hope you've had a good Saturday, and to come at 8 o'clock at night Eastern time to a exam study session is quite a commitment. But as you know, in nursing school, there's no leisure time, is there? No leisure time. Well, okay, so diabetes in pregnancy. What can you tell me about a diabetic during pregnancy? What are some risks associated? Let's just talk about those who are pre-gestational diabetics. So a client who's a diabetic and then she becomes pregnant, okay, like type 1 or type 2. What are some things you're concerned about?
I have a question before we start, please.
Okay, sure, Lucy, go ahead.
As I was reading the chapter, when we're talking about like when the mom has like engorgement, and it says that we should do like cool compresses, but when I was attending a different lecture with another professor, she mentioned warm, like you would take a warm shower before breastfeeding or something if you're engorged.
Okay, so yes, that content is starting next week. We really haven't talked about that too much when we start talking about the newborn. But yes, it depends. Is the client breastfeeding or not? If she's breastfeeding, yes, it would be more comfortable for her to take a warm shower and express some of that milk. Just remember, the more the breasts are stimulated, the more milk that's going to be produced. So if she does not want to breastfeed, we don't want her to do that. We want her to use cold compresses, binding the breast. So wear a very supportive bra, maybe cabbage leaves. That's what we usually teach, cabbage leaves, because they're cut really nice, and you can put ice inside of them and apply them to the breast. Okay, so that's a differentiate. When do you do warm and when do you do cold? Okay. Now with mastitis, you want warm. Okay, because you want that milk to be released. Okay. Any other questions? Okay, you can always interrupt me. So diabetes in pregnancy is a real high risk. Usually we're dealing with gestational diabetics, not type 1 or type 2. So if we have a type 1 or type 2, at the beginning of the pregnancy, even though even before, right before she gets pregnant, if she has high blood glucose levels, what are some things we're concerned about during that first trimester? Who
Um,
can tell me?
Things that could be wrong with the fetus, like defects, birth defects.
Okay, okay, okay. Birth defects, so congenital defects because of the hyperglycemia. What else might happen? What else could happen in that first trimester?
Could miscarriages or stillbirths happen?
Yeah, miscarriages, definitely. Um, Miscarriages, spontaneous abortions. Okay. And then as she progresses through her pregnancy, um, she can have all kinds of problems too. Okay. So I was trying to do two things at once here, bringing up my diabetes. Um, Let me see here. I'm going to share some slides with you. Okay. So the difference, let's talk about the difference between the diabetes. So let me go back a slide here. Oh yeah, this is fine. So we have pre-gestational, which are type 1 and type 2, and those are clients that have a history of diabetes and their A1C is out of control. Now, their A1C before pregnancy greater than 6.5 means that they're hyperglycemic, right? And those clients are one that can easily have a spontaneous abortion. That's why we don't see that many, or congenital anomalies in the fetus, okay? Gestational diabetic doesn't have diabetes until the middle of her pregnancy. It begins during the pregnancy. Okay. So remember that during pregnancy, we don't use the A1C. Okay. Because we want to know what's going on with our client every day. Okay. We want the client to be aware of what her glucose is moment by moment, or at least couple hours by a couple of hours. And we want her to be very involved in strict blood glucose control, exercise, good nutrition. So we teach them to do use their glucometer. The A1C is not effective, okay, because there's a little bit of physiological anemia. In other words, the red blood cells are diluted a little bit in the large plasma volume, so A1C is not as accurate. Okay. Also remember that it's the beginning of the pregnancy that the needs for insulin are less. So we have to adjust the medication. As she gets closer to that 20 weeks, and as we begin to diagnose gestational diabetes in other clients, that's when the need for insulin continues to grow. Okay. And if we can't control her blood sugar, then she's going to have problems throughout her pregnancy. So let's look at those problems. We've already talked about early antepartum versus late, okay, and labor and birth. So cardiac deformities, limb deformities, spontaneous abortion, things like that. But late second trimester and third trimester, we're thinking of things like polyhydramnios, a lot of amniotic fluid around the baby. Okay, macrosomia, large baby, extreme prematurity. And then after delivery of this baby, hypoglycemia in the baby and respiratory distress. So birth injuries to mother and or baby, shoulder dystocia, all of those things. And this is the effects of not controlling glucose during the pregnancy. So we have a lot of teaching to do with our diabetics. Let's see, let me stop sharing this one.
So,
Yeah,
question.
yes.
I do know about the management for the blood glucose. So what would we do during the first trimester, second and third for management?
Okay. Okay. So we really want our pre-diabetic or pre-gestational diabetics to go through some preconception counseling to get her blood glucose low or below what she's used to, maybe. Okay. So we want it between 60 and 95 first thing in the morning, fasting. Okay. We want her glucose 2 hours after she eats to be less than 120. So this is what we're teaching her and managing her all along. Okay, this is what we're teaching. And then as we do that, we might have to give medication. And then the third trimester, we're watching fetal growth and amniotic fluid. Okay. Does that answer your question, Saina?
Yes, thank you.
You're welcome. That was a good question. Let's see here. So I'm going to review, for those of you who attended Professor McGuffey, I've got a case study I want to show you. And we're going to go over that because I don't think all of you did. Move this over so you can see it a little bit better. Okay, so Anna is a client. She's 35-year-old, African American, gravida 2, or you can read this, pair 1. She's in the 26th week of her second pregnancy. She had, for her first pregnancy, she developed gestational diabetes. Okay, but she had a large baby. She did not lose weight she gained during her first pregnancy, and now she's 30 pounds over her ideal weight at the 26th week. And now she has, let's see, so she's been diagnosed with gestational diabetes, okay? So her history, risk for developing gestational diabetes would be obesity, gestational diabetes in a previous pregnancy, family history of diabetes, and those are probably the 3 top risk factors for any client to actually develop gestational diabetes. So this is a case about a gestational diabetic. So where am I here? Okay, so we put her on a treatment plan, and here is, I think I answered the questions. I'm not real familiar with these slides, but so first we're going to assess the knowledge of our client, right? What does she understand about diabetes or gestational diabetes? What does she know about her glucose? What is she on, any medications? What should we do? Okay, so which of the following recommendations are we going to, how are we going to manage her diabetes? So we're going to select all that apply here.
B.
2 hour post meals less than 120. That's correct. What else?
C.
C. Okay. It's not really the mainstay.
E.
Moderate exercise program. Yes, true. And
Answer.
insulin. Go ahead.
Would it depend on if they are type 1 or type 2 for insulin?
Insulin is, according to the research, is really the most ideal medication to use during pregnancy to monitor and maintain blood glucose levels. But we see in practice that we do use other drugs because of compliance. If you have a client that's never had to inject anything into herself, it might be a real obstacle to get her to do that during her pregnancy. And there are safe medications that we can use, like sulfonylureas, like glyburide. Okay, we can use those medications or even metformin and safely during pregnancy. But it is most ideal to use insulin. Okay, so 2 hours, 120, less than 120 is correct. Dietary modification, yes, but it's not necessarily the mainstay. We're more concerned that what she's eating and that she's exercising and any medication. Okay, so that dietary modification is a mainstay. A lot of times women can get by with just watching what they eat along with exercise. Okay, diet instead of taking medication. Okay. So now Anna's in the 30th week of her pregnancy and she's at an appointment. She says she's heard about some of the problems that can affect the baby when a mother has diabetes, and she's worried. She's having trouble sleeping. So the nurse needs to provide a plan to help her with her anxiety and most emotional support. Okay, so let's talk about the risk to the fetus now. Okay, so infants born to women with gestational diabetes are at risk for what? Decrease, increase, discordant, or restricted fetal growth?
Increased.
Increased. Yes, increased fetal growth. That's the answer for number 1. And what?
Macrosomia.
Macrosomia. Big babies. They have broad shoulders and trunks. Their trunks are larger. Okay. Associated risk and associated risk for neonatal what? Option 3. What?
Distress.
Distress. Yes, distress during labor. And option 4 would be what?
Hypoglycemia.
Hypo, yes. Once you clamp that cord, glucose is no longer available to that baby. So now we have to feed the baby. Okay, their sugar levels will drop rapidly. So we recommend that diabetic breastfeed her babies, of course, because if she breastfeeds her baby, that means her baby has reduced risk of developing diabetes later in life. So we're going to encourage our diabetics to breastfeed their baby. It also helps a diabetic to control their glucose themselves. So we're teaching them as soon as possible to go ahead within that first hour at least. Into the second hour, we need to feed that baby, and we want to do it as soon as possible. That's the best time to teach a mother about breastfeeding, when they have the baby. And you can observe the positioning of the baby, the positioning of the mother, how the baby latches, and you can it's a real opportune time for teaching. Okay. Diabetics are also at risk for preeclampsia. Somebody describe to me what are some early symptoms that preeclampsia in a client are evolving.
Tachycardia.
Tachycardia for preeclampsia? No.
Blood pressure.
High blood pressure, yeah, high blood pressure because of the effects of it on the kidney. So high blood pressure is one of the early signs. In fact, she has to have high blood pressure above 140 or above 90 to be diagnosed with preeclampsia. Okay, so high blood pressure. What else?
Would headache, or is that later in?
No, headache is very common. There's a triad. High blood pressure, headache, protein in the urine,
Okay.
and edema as she progresses. The literature teaches us that pulmonary edema is diagnostic also of preeclampsia. What else?
Would blurred vision be?
Okay, blurred vision, more of a seeing spots
Mm-hmm.
and bright lights. Yeah, so visual changes. It could be that. Let me see here. Okay, so let's go through preeclampsia. There we go. So let's look at Professor McGuffey's next case about preeclampsia. Okay, so you can go ahead and read this. Olga. So in this description, oops. In this description, tell me which symptoms and signs in this description indicate that she's developing preeclampsia with severe features.
Headache,
Or blood pressure? Of blood pressure, yeah.
Oh my goodness. What we call this severe preeclampsia, don't we?
Yes.
Okay. Yeah. What else?
headache of 2 days.
She's
A
not
headache of
eating.
2 days. Yeah. Severe features would be not necessarily headache, but blood pressure. Would you say edema,
Shortness of breath.
shortness of breath? Yeah, definitely. Shortness of breath. What else?
Protein, protein in the urine.
Yep. Protein in the urine, deep tendon reflexes,
The
clonus.
the edema, weight gain of 6 pounds in 1 week.
Okay, 6 pounds, 6.6 pounds in a week. Okay. All right. So what would be a priority here as a nurse? What is should your care plan include with severe preeclampsia?
I would say the shortness of breath would be priority.
And the
Okay,
circulation. So blood pressure, we should be able to manage that.
okay, we might have to give her antihypertensives to get that blood pressure down, definitely. We certainly don't want her to have a stroke, do we? So we are going to need magnesium sulfate, okay? So what else as a nurse, what is your care plan include besides management and monitoring with of magnesium? What else should your care plan include with
Hot
severe?
Seizure precaution.
Seizure precautions, yeah. So what does that include?
Padding of the rails on the bed, dimming the lights.
Good. Padding of the rails, bed down. so decrease stimulation, okay? You need what else in the room in case she has a seizure?
Suction.
So anytime you go into a client's room that is high risk or that is very sick, or if you're admitting a client with risk for seizures, or a risk for aspiration, you always need to make sure the equipment in the room is available and it's working. Okay, so always test the suction, make sure it works, make sure you have tubing in a collection canister, make sure you have oxygen, that a meter that flows, and you have the tubing. Okay, it's part of your responsibility as a nurse to make sure you have everything that you need, because a clonus is a sign of imminent seizure if we don't do something about it. So we need to be prepared for the worst. Okay. What else? What if you notice petechiae around underneath the blood pressure cuff? What would you think could be occurring?
Bleeding.
Okay, so petechiae. What is petechiae? What does it indicate?
Like it's like buzzing.
Is it like a hemorrhage?
It's
Or like a hematoma?
it's petechiae are like little tiny broken blood vessels or bleeding blood vessels, you might say. So platelet levels are low. Okay. Why would platelet levels be low?
Platelets. An infection maybe?
I would say oxygen.
I'm going backwards. So preeclampsia,
Yeah,
one of the
help.
signs, one of the signs of preeclampsia could be the development of low platelets, which would be called with severe preeclampsia. What? What'd you say, Kimberly?
Oh, help.
HELP syndrome. HELP
Mhm.
syndrome. Okay. So if your client has preeclampsia and then things begin to get worse, her blood pressure goes up above 160. Okay. And she's got petechiae underneath the blood pressure cuff. She might be developing hemolysis. Liver enzymes are elevated higher, low platelets, which is the petechiae, right? Okay. So what's the other symptom? What would your client also complain about if she was developing HELP syndrome?
Pain in the stomach or the right?
Yeah, it's the liver, right? It's
Yeah.
the liver. Remember, preeclampsia attacks or affects the brain, the lungs, the kidneys, and the liver. Okay, so with HELP syndrome, it's a worsening situation. Okay, so her liver's gonna start hurting. She's got hemolysis going on. She's got elevated liver enzymes, low platelets, petechiae, epigastric pain. Okay, so we need to address that. So that is the continuum of preeclampsia, going into severe, which is the high blood pressure, and then maybe into HELP. Okay. Okay. So we began her on her magnesium per the protocol. She was placed on fetal heart rate monitoring. She still had headaches and some blurred vision. Her blood pressure remains above 110. So let's see if I jumped ahead of myself. Okay. So what are some indications here? So encourage the family members to visit. Is that indicated or contraindicated or non-essential information?
Contraindicated.
Yes, it certainly is contraindicated. She needs rest, right? Okay. Monitor serum levels of magnesium sulfate every 24 hours.
Contraindicated because it needs to be sooner. than 24 hours.
Yeah, it might need to be. It's not really contraindicated. I know what you're saying.
Okay.
It's indicated that we monitor it, okay? And it just depends on the situation. If we're watching our client, assessing the client, and we begin to see signs of toxicity or signs that it's not working, it's not therapeutic, then we certainly would draw some, okay? So monitoring maternal vital signs, level of consciousness, respiratory rate, which is vital signs, fetal heart rate, deep tendon reflexes. Is that indicated, contraindicated, non-essential?
Indicated.
Indicated.
Yes, absolutely. Oops, sorry. Indicated. Monitor urine output every 12 hours.
Indicated.
Yes. You might want to do it very, if you've been, if she's your client and you went in at noon and she had 40 mLs of urine in the Foley, or she put out 40 mLs of urine, and then 2 hours later there was only 60, then you would want to monitor it more often. Okay. And you might, and there's other signs of subtherapeutic levels of magnesium. How about maintaining a quiet, darkened environment?
Indicate.
Schedule a non-stress test.
Non-essential.
Not essential.
Yeah, right. We don't need a non-stress test. We're monitoring hour by hour our baby. Okay. So remember, for preeclampsia, any client that's receiving magnesium sulfate, we're going to monitor vital signs, level of consciousness, okay? Deep tendon reflexes, fetal monitoring, urine output, visual changes, assessing pain. So which of the following nursing actions lead to quality patient outcomes? Select all that apply.
A.
Mhm.
Would B be one?
In this situation, it would be.
C.
Now, why would you be administering pain medications around the clock?
No, never mind.
Okay, if a client asks for them, yeah.
Okay. D.
Yep.
I would say E.
E.
E, yeah.
F. Well, maybe sooner than 4 hours.
Or not as often, every 8 hours,
Not as
yeah.
often. Okay.
Yeah, if she's not having any, when you do her vital signs and her saturation is fine, and she's alert and oriented, not complaining, I wouldn't think you would need to do it every 4 hours unless she has experienced some shortness of breath from the preeclampsia. But above, it says that the vital signs have stabilized, so she's not showing signs. Okay, all right. What are some signs of toxicity? What would be signs of toxicity? Magnesium toxicity. When you think of,
Would it be deep tendon?
what about the deep tendons?
I believe it's that's magnesium, right?
It would be magnesiumemia. Too much.
Right.
You're gonna have less urine with toxicity.
Yes, because what happens is, see, let me do something. I'm trying to do something here. Yes, the magnesium actually paralyzes the kidneys. Okay, so medical management. So when we think about toxicity, we put it here. When we think about managing with magnesium, our preeclamptic clients, we have to maintain a therapeutic level of magnesium to reduce the signs and symptoms of preeclampsia. But with infusions, it depends on the client, but sometimes we can get too much. Okay, she can actually become toxic. So when we think about the clinical signs of preeclampsia, the central nervous system, so that would be level of consciousness, deep tendon reflexes, right? And of course, heart rate, vital signs, basic vital signs. The lungs would include auscultation, so respiratory rate, okay, those things. So when we're managing, those are the areas we are assessing, okay? So if she's toxic, in other words, if her level of her central nervous system is depressed severely, what would you see in toxicity?
Decrease in respiratory rate, consciousness.
So lethargy, maybe?
Yeah.
She's not alert anymore. She's very drowsy. It's hard to wake her up because we've depressed her central nervous system. So if you walk into the room and your client is lethargic and you try to wake her up, her respiratory rate is 10 or 8, she's probably toxic. You assess her deep tendon reflexes and they're hypoactive or missing. DTRs may be a 1+ or less. Okay. Bradycardia. Low blood pressure, hypotension. Okay. So that's what you would find. So what would you do in that situation?
Give them calcium gluconate.
Okay. But before you do that, what would you do?
Stop the infusion.
Stop the infusion. Yeah. Stop the infusion, stimulate them, wake them up, give them some oxygen, get a primary line of fluid going because you want those kidneys to produce. Okay. Call the provider. And then the provider will let you know if there is a protocol, and there usually isn't, to give calcium gluconate. You're not going to just automatically give it. You have to be careful because if you give it, because you give it IV push, you might send her in the other direction. Okay. So that's toxicity. So now that, let's see, stop sharing that. So know the signs and symptoms of preeclampsia. What's the management? What would you see? Okay. What could you see if she was becoming worse? What is severe preeclampsia and HELP syndrome? Remember, HELP syndrome includes the hemolysis, so bleeding. You might see a little blood-tinged urine. At least you might see petechiae. Okay. Let me. Let's talk about another client. So you have a 40-year-old with a history of in vitro fertilization. Okay. We're admitting her to the hospital to induce labor because she's at 42 weeks now. She hasn't wanted to be induced earlier, and we're at the post-term stage. So post-term pregnancy carries a lot of risk, doesn't it? Okay, so you admit the client and you begin your assessment. So what is your priority assessments? What's the first thing you would want to do? I said 1 to 5, and there's only 4 choices here. So what's the first thing you want to do?
Identify the client will be the first thing that we would do.
So she's in the hospital. We're going to induce her into labor. What else would you want to do?
Put on gloves for standard precaution.
Yes, you might even put those on first before you even identify the patient, right? What would you want to do next? Do you want to apply a fetal heart monitor first?
Yes.
Yes.
Yeah, you kind of want to know what's going on with the baby, or at least listen to fetal heart tones, right? Okay, and then assessing the cervix would be your step here. So why do we have to assess the cervix?
To see if she's dilated?
Okay, yeah, we want a baseline information, right? We want baseline. What other assessment tools should the nurse use to help prepare for labor induction?
Bishop score.
Yeah, so what is the Bishop score?
That's when you check how far or close she is to labor.
Okay, that's one way of putting it. Yeah, so it's specific. It's a tool that measures that we use criteria. Is the cervix dilated? Is it effaced? Where's the fetal station? And we have a score, so we total the amount. And if it's 5 or more, 6 or more, there's no set amount. It just depends on the provider. It determines whether we need to do something else. Okay. Ultrasound, we might want to get an ultrasound as well. Why would we want to get an ultrasound before inducing her?
Maybe to check on the fetus to see, I guess, if it's, would we check if it's in the right position, I guess, if it's head down or other way?
Right. The lie. We want to make sure it is head down. We're not going to start induction with a breech baby. Okay. So here's the Bishop score or Bishop scale. The consistency, effacement, dilation of the cervix, the fetal station, and we use all these criteria and then we add it up. And ideally, 6 and above is more promising. that we could go ahead and start labor with oxytocin. Okay.
So if it's less than 4, do they do something else? Do
Yep.
they use
What do
like
we?
the gel? Okay.
Yep. Getting to that next. Okay. So the business score is 4, and the provider orders what? What kind of gel? What's it called?
It's prostaglandin. How do you say it?
Prostaglandin.
Yeah, that's it.
That's it. Prostaglandins like Cytotec, misoprostol is one, dinoprostone, those are the brand names, but Cytotec is a brand name too, misoprostol. But they're prostaglandins and they help the vagina. We're gonna, the prescription says to be placed in the vagina to help blank the cervix. What are we doing to the cervix?
Softening it.
Softening the cervix. Okay. So we're going to induce with a prostaglandin, and that helps to soften the cervix. So we can begin labor with oxytocin. But this client, 6 hours later, because sometimes we'll put prostaglandin in several times. Of course, we can use a gel or we can use an insert. There's different ways of using prostaglandin. And we might have to do it more than one time. We want the cervix to become dilated. So 6 hours later, after we began the prostaglandin, a lot of times we do this at nighttime. We admit the client at night, the night before, and we begin prostaglandin, and then we schedule the induction for the morning. Okay, but 6 hours later, our client with the prostaglandin begins having contractions. And that's very possible because prostaglandins can cause contractions. And these contractions are lasting 2 minutes. So the nurse puts on the, well, I'm not going to tell you. What's your priority when the client calls a nursing station and says she's having contractions? What is your priority?
We need to know how far apart the contractions are.
What's your priority? The list is down here in this list.
We can't see it.
Oh, I guess it would help.
Putting the fetal monitor on.
Yeah, it's not already on. We need to make sure we apply the fetal monitor to see how the fetus is doing.
Mhm.
And if she has a prostaglandin insert in, we need to remove it. Because her contractions are lasting 2 minutes. That's too long. What's a maximum contraction length ideally?
Uh, 1 minute.
90 seconds.
1
Okay. So you would want to apply the fetal monitor, remove the prostaglandin insert, call the provider. Would you want to start oxytocin?
I don't think so.
What's your rationale?
Does the oxytocin start the contractions?
Yeah,
So
yeah.
if she's already contracting, then I don't think they would have to start it.
No, and they're lasting too long anyway. So
Okay.
Yeah, so we'd want to, if she had contractions, we'd want to certainly stop the oxytocin, but we're not going to start it. Okay, we're just going to we're going to begin to monitor contractions, watch the strength, measure the strength and the frequency, the duration. So, so an hour after you remove the prostaglandin insert, contractions are regular and occurring every 2 minutes. What's our maximum contraction amount?
90 seconds.
We don't want any more than 5 contractions in 10 minutes. If she's having one every 2 minutes, that means she's having 5. So she delivers the client or delivers the newborn. Okay. Yeah, she delivers the newborn. It's late at night. So this is called a precipitous labor. Onset and delivery within 3 hours. So she had a very precipitous labor in birth. And it caused pelvic floor laceration. That took an hour to repair. Okay, it's one of the risks with precipitous labor. Okay, so she had a laceration. She lost 700 mLs of blood. Skin to skin with newborn began after the repair work. All right. So what concerns do you have as the postpartum nurse have for the client's safety and well-being? Precipitous labor, older woman, traumatic birth, damage, loss of blood, and then postponing skin to skin for an hour, which is okay, acceptable. It's not ideal. We would like to do it right after the baby's born, but because she was having pain and we had to do surgery. So what concerns do you have?
So I think she can be at risk for postpartum hemorrhage since she lost like 700 ml, which is for vaginal birth, shouldn't it be less than 500?
Yeah, you're right. So she is at risk for hemorrhage. That's right. What else are you going to watch her for?
Infection.
Okay, yeah, we're going to watch her and we're going to teach her, right? What kinds of things would you teach her during this period, postpartum?
She should
As
do
you're
the pad saturation amount and also how to clean herself.
okay, yeah, you need to teach her pericare, right? Hygiene issues. Good. So other than a laceration, could she have experienced any other injuries with a precipitous labor? What else could have happened? And what would the client complain about? During a traumatic labor, clients might begin to complain about pain.
Hemorrhage? Okay.
We talked about the hemorrhage. No injuries. What else? Other than a laceration, what else could develop?
Pain.
Is it a hematoma?
Yeah, like a vulvar hematoma. Yeah. So what would you do? So the picture in the middle is a vulvar hematoma. So if you notice, if your client calls out and says she's hurting, and see, the hematoma might not develop for, a day or more, because it's a slow bleed. Okay, so you need to call the provider. Mhm.
And that would
Call,
lead to a hysterectomy.
a vulvar hematoma? No, no, this is external genitalia. Can you see my picture?
Yes, I see it.
Okay, yeah. And there's a YouTube video here that you can watch about the perineum. So the first picture is an episiotomy, which is intentional, right? But you're going to assess it like you would lacerations. You're going to look for bleeding, make sure the stitches are intact. Avoid using rectal suppositories. And then that third picture are hemorrhoids, internal hemorrhoids. So she might have some hemorrhoids too. So what we can teach is ice packs, right? Which Hazel compresses are good for hemorrhoids? Sitz baths, warm water for the first 24 hours improves the healing process and provides some comfort for the client.
I read in the book that they can also get stool softener.
Yeah, oral stool softeners, oral.
Yes.
Yes. Okay. So all of these are right. These are just options. We can teach her all of these things. Okay. See, I think
Professor, so when would we do the suppository stool softener? I mean, glycerin, suppository glycerin.
Anytime, as long as she doesn't have an episiotomy or a laceration or any other kind of injury. Okay. Yeah, we need to avoid those if there's injuries. Does that make sense?
Yes.
Yeah. Um, let me see here. Let's talk about postpartum hemorrhage. Okay, let's talk about postpartum hemorrhage. Let's see. This is one of Professor McGuffey's slides. Go ahead and read it. Okay, so this is a client who had preeclampsia with twins, and we had to induce her because of the preeclampsia. Okay, so with preeclampsia, giving magnesium sulfate, we usually continue magnesium sulfate infusion for 24 hours after delivery. And this client is now 8 hours and she's getting 1 gram. She does have a Foley in place because we need to monitor her urine output, right? With magnesium. So it looks like the oxytocin was discontinued because her fundus was firm and it was located 1 centimeter above the umbilicus, which is good, and just a moderate amount of lochia rubra. So in this case, what factors place Marty at risk for excessive postpartum bleeding? What is it about her history?
She had multiple births.
Yeah, she's a multigravida, right? She's a multigravida. Okay. What else?
Second degree laceration.
All right, laceration. It was a twin pregnancy. It's another one. And sometimes magnesium sulfate because it relaxes the uterus a little bit, okay? All right. So you're performing your postpartum assessment on Marty. And you know that the priority is the fundus. And you palpate it and it's boggy. And it's located 2 centimeters above the umbilicus. And so you know that the first thing you should do is massage the fundus. It remains boggy. What would you have done in this situation if it was deviated to the right? What would be an important thing to do first before massaging?
Should we assess the
Bathroom.
Yeah, empty that bladder. Yeah, void. Have the client void if it's deviated. Okay, but it wasn't. It was just boggy and it was above the umbilicus. So you massaged it. The peri-pad was soaked completely. More lochia is noted under the pad, on the underpad. Marty says she feels weak and is worried that something's wrong. Vital signs are 110/60, pulse 90, respirations 22, temperature 37.8, saturation 95%, and urine output 150 since giving birth 8 hours ago. So she notifies the healthcare provider and initiates the unit's protocol for postpartum hemorrhage. Okay. What's the appropriate actions for the treatment? This is not a priority list, but just which ones are appropriate for the treatment of postpartum hemorrhage.
We're gonna stop the magnesium.
Okay. Okay. Yeah, because it does reduce contractility a little bit. Okay. All right. There we go.
Massage the uterus.
Okay.
I'm not sure about the expressing the clots. I want to say yes.
Yes.
Okay.
Yeah, they're gonna cause more bleeding. We got to get rid of them.
Okay.
So we need to get rid of the clots. Anything else? Oops.
I think that's it.
We probably need to give some medication, don't we?
Okay.
It says administer Methergent as a primary medication. We might, she doesn't have oxytocin going anymore, but Methergent would be, since she doesn't have her IV anymore, she probably has a peri, or a lock, saline lock. But we need to give her some medication.
Okay.
Okay. All right. So what you did worked. The fundus is now firm and located just a centimeter above the umbilicus, and the lochia rubra is moderate. However, Marty states that she's feeling dizzy, lightheaded, and nauseated. She appears pale, and her skin is cool. Vital signs are 80/50, pulse 110, and thready. Respirations are 28. O2 saturation is now 93. Urine output is scant. The nurse recognizes that Marty has signs and symptoms of hemorrhagic shock and immediately takes action. Okay, so hemorrhagic shock is similar to cardiac decompensation. You know, a little tachycardia there, right? So it's like the heart is trying to compensate. And if we don't interrupt, she could actually go into collapse. So activate postpartum hemorrhage team or rapid response team. Would that help? Yes. Did I lose you? Monitor vital signs and other indicators of hypovolemic shock every hour. We need to do it often.
Yeah, more often than an hour.
Yeah. How often would you want to?
Every 15 minutes.
Every 15 or 30. Once she's, if you're checking on her blood pressure, that's a late sign, remember? Okay. So you do want to monitor her. Measure and record amount and type of bleeding by weighing, counting saturated pads. Is that going to be effective?
Yes.
Yes. But if she's other signs of shock, whether nursing interventions below are effective. Okay, I'm trying to follow this myself. Semi-Fowler's position, so we're going to put an X on this one. What about Semi-Fowler's position?
Hmm.
No, that would make it worse, right?
Yeah.
That makes the heart work harder. How about oxygen, non-rebreather mask?
Yes.
Yeah, that would be 100%, right?
Yeah.
Okay. Infuse IV fluid slowly.
We should give IV fluids.
It says slowly.
It shouldn't be slowly.
Yeah, that wouldn't be very effective. We need to infuse them quickly. Okay. All right. So what are some signs of cardiac decompensation? If you have a client that has some postpartum bleeding or uterine rupture, maybe it was a traumatic labor and delivery, her uterus actually ruptured, maybe it's precipitous and the uterus ruptured, and you're managing fluids and everything, and you're doing all the things that you're supposed to do for hemorrhaging. If it's not working, what you're doing, what your interventions are ineffective, the heart then begins to decompensate. In other words, it's worn out. What are some things you would see?
Would we see like shortness of breath, like dyspnea?
Yes, pale skin, clammy skin, shock, and heart can no longer keep up. Okay. Let's see, what do you know about DIC? Disseminated intravascular coagulation. What are some signs of DIC?
Bleeding.
I only heard part of a word, Shayna.
Bleeding, sorry.
Yeah, so bleeding. Yeah. How would you recognize what in clinical signs? What would you see if your client was bleeding from DIC?
Nose, mouth,
Okay, so some oral membrane bleeding. Where else might you see bleeding?
stool, urine,
Okay. So
Would-
just think about,
Would it be bleeding, like at the site of the IV?
okay, yeah, any invasive, any area where we've used invasive methods. Okay, so an IV site, a central line is an IV site, but a central line may be a wound. If they had a C-section and they were developing DIC, the incision itself would be bleeding. Yeah, so DIC means that there are no clotting factors remaining. They've been used up, and so they're bleeding. So we treat this the same way we would do with any other hemorrhagic shock. Okay, IV fluids, oxygen, get some help in there. Oh. Well, is there anything else you want to review? So those particular concepts, make sure you know those well. What are the clinical signs? What are the risk factors associated with it? Was the treatment and the management? How do you know it's been effective? Any questions? And so nobody here takes the exam on Monday? Nicole, you're in Wednesday, aren't you? Yeah.
Yeah, Wednesday.
Okay. Okay. And those of you are my students. Any of you taking the exam on campus?
No.
Okay.
No.
Okay. All right. Well, thank you all for coming. If you don't have any more questions,
thank you.
Yeah.
you're welcome. If you think of something, if you want me to go over any of those again as you study, let me know. Okay. So don't forget to look at all the videos that we've saved for you or we've recorded for you. You can read those.